Good morning. Thank you for the introduction. As was introduced, I'm a surgical pathologist. In our branch of medical diagnostics, we characterize and classify tumors from biopsies and tissues that are resected by our surgeons. What I'd like to do in this talk is to show you a few ways in which new quantitative technologies promise to transform our clinical practice and our discovery efforts in clinical research. So for decades, diagnosing cancer relied principally upon the review of H&E stained sections like the ones behind me for classification by pathologists into tumor taxonomy systems. Genomic technologies have recently expanded our taxonomy and our capabilities. These images are from two subtypes of rare brain tumors called craniopharyngiomas that arise near the pituitary gland, causing tremendous lifelong complications, blindness, endocrine disorders, uncontrolled obesity, and even strokes. With genomic tools, we have identified genetic mutations in these tumors in oncogenes that drive each of the tumor subtypes behind me. We've shown that the tumors of the papillary subtype have activating mutations in oncogenes, in the BRAF oncogene, which make them highly sensitive to the same drugs that were developed to treat BRAF mutant melanomas. Our partners and colleagues at Mass General Hospital treated a patient with a papillary craniopharyngioma with targeted therapies, and within only 1 month, the tumor shrank by 90%. This is just one example of how genomic tools and genomic testing for mutated oncogenes has transformed our capacity to help cancer patients. And this was kind of driven by what we call HI, human intelligence. So exceptional responses have also been achieved using immunotherapies for brain cancers. In the treatment timeline behind me, you can see the difficult clinical course of a patient who had undergone 6 surgeries for recurrent meningioma, multiple courses of radiation, and treatment with experimental drugs, all to no avail. The tumor had eroded through the patient's skull. At that point, she was enrolled by our good colleague, Dr. David Reardon at Dana-Farber and Brigham Health in an anti-PD-1 immunotherapy clinical trial. Unlike the dramatic response seen in the prior patient, the craniopharyngioma patient, this patient had a very different dramatic response. The tumor grew very fast. However, tissue removed during a final surgery before planned hospice showed a remarkable change in the tumor, where previously the tumor cells that had been present before immunotherapy were entirely gone. They were replaced by a burst of anti-tumor immune cells. Molecular characterization of the patient's samples revealed underlying reasons for this response, this incredible response: a mutation in a DNA repair gene that increases the odds that the body's immune system sees the tumor cells as foreign and targets them for destruction. This biomarker can now be used to identify other patients with recurrent meningiomas that might respond in a similar manner. This patient remains disease-free nearly 3 years after treatment. So despite the advances in targeted therapies and immunotherapies, many patients have tumors for which we do not have any effective treatments. For these patients, a newer paradigm is emerging, aiming to characterize tumor properties even more deeply, leveraging and integrating multiple powerful analytical platforms. In one set of techniques, tumor cells are disaggregated into individual cells, studied with analytical approaches, and even functionally interrogated. In another set of techniques, the tumor cells remain intact, and they're not disaggregated. They're studied in their native context, in their native architecture, with their native morphologies. In our work, we're trying to develop computational and algorithmic innovations that will allow for the deep analysis of these type of samples, but also for the integration of information across these samples. So for some examples, and in that integration, obviously AI and machine learning approaches will be very important. So this is an operating room in 1923 at the Brigham, and this is our current advanced multimodality image guiding operating suite, the Amigo. The powerful technology in this room allows our surgeons to localize tumors and to develop and validate imaging technologies for improving patient care. In the Amigo, we have cited a mass spectrometer for the real-time molecular characterization of surgical tissues. Mass spectrometry is an extremely sensitive modality and an analytical tool, and does not require the labeling of molecules. In principle, any molecule or sets of molecules can be analyzed. For now, we have the first IRB-approved protocol for the use of information derived from mass spectrometry to inform surgery. We use either individual molecules, such as a tumor-specific metabolite, or multiple markers and multiple marker classifiers derived from multivariate data analysis and machine learning algorithms. From our reference data, we can then classify new data and new samples, and then visualize our classification results over segmented MRI. With these classifiers, we can, in real time, discriminate tumor from non-tumor, tumor grade and tumor prognosis, and we can also identify drugs within the tissues and treatment response predictors in the tissue. In this one example behind me, you can see a glioblastoma sample that was removed from a patient who was treated for 8 days prior to surgery. In the circle is actually normal brain, and the drug is represented in green. In that case, the drug accumulated in the normal tissue and not in the tumor, which was surrounding outside of the green circle, and that's important information that is critical to know. So increasingly, both in clinical samples and in research samples, such as this MALDI data set of a glioblastoma grown in a mouse brain, we are using deep learning to identify encoded features and capture molecular structures in the high-dimensional data. This clustered image of these encoded features reveals biologically interesting tissue attributes, such as tumor heterogeneity. There's in clusters 1, 2, and 8 in there in blue, red, and green. You can see that there are different properties of the tumor cells. And now, using these models, we can analyze new data in just a matter of seconds and develop similar understanding of the tissues that we're seeing. So these have tremendous opportunities for diagnostic impact. These technologies clearly promise to disrupt our current paradigm for intraoperative diagnosis. Rather than waiting 30 minutes for an intraoperative pathology report, surgeons may, in some cases, be able to derive information in seconds using mass spectrometry in the OR suite, and to use that information to guide their surgical decision-making, relying less on frozen sections, less on intraoperative MRI, and spending less time, therefore, in the operating room. And this is sort of a little schematic of the transformation that we envision. So with powerful analytical techniques like mass spectrometry, there's one downside. The resolution is not as good as with optical imaging. So we've taken on other approaches. One is tissue cyclic immunofluorescence, which we call T-CyCIF, which provides single-cell resolution as well as subcellular resolution. And off to the right is a little video of some of what that data looks like, multiple markers on tissues. We use antibodies that are conjugated to fluorophores, incubate them with tissue sections and a DNA dye, then perform optical imaging, photobleach the antibodies, and then do multiple cycles of imaging in this way on the same tissue section. We really are fond of this approach because it's rather simple. It uses commercially available antibodies. It works on archival tissues. It's fast. It uses available microscopes. It's really the kind of thing that you want when you're trying to do robust research. It doesn't involve expensive instrumentation. And on top of it, we're doing this in an open, collaborative environment in the Lab for Systems Pharmacology at Harvard Medical School, which is a space that's been funded by the Mass Life Sciences Initiative, where we're promoting open source approaches with this, reagent validation, full disclosure of protocols, and full data sharing so that we can mine this information with our colleagues. Now, machine learning plays an important role, for instance, when we're trying to identify cells in human tissues. Human tissues are pretty complicated to work with. The cells are of various sizes. It's often difficult to decide what one cell is and separate that from another cell. So we use machine learning approaches to define what a cell population is, and we're even able to use machine learning to segment individual subcellular structures like primary cilia here, but we can see other subcellular events rather well. And then we can take that data and cluster it, as you see off to the side there, in a diagram that is, I think, really kind of powerful, because what it shows is that in each column is an individual marker, and in each row is an individual cell. This is data from 75 breast cancer patients. So 325,000 cells are presented before you, and they're clustered, showing different tumor types, tumor cell types, stromal cells, immune cells, and their various states. And we're at the point right now where we're analyzing the intensity data of the biomarkers, but in time, with AI and other approaches, we'll be able to extract other features, nuclear size, nuclear shape, proximity of cells to one another, and other features which we can't easily perceive with the human eye or imagine at this time, and using those to define new tumor cell states. Using this approach, we'll be applying these powerful technologies as part of the Human Tumor Atlas Network. That's an NCI-sponsored initiative of the Cancer Moonshot. It's a TCGA-like attempt to build high-plex atlases of human cancers. 10 teams from across the country, including ours, will be using next-generation analytical approaches to deeply phenotype a range of cancers and precancers. And we hope that we'll be able to reveal important vulnerabilities in tumors that will ultimately benefit our patients. So I thank you for attending this, and a special thanks to my colleagues, my wonderful colleagues across the Boston area, including Peter Sorger, Natalie Agar, Priscilla Brastianos, and David Reardon. Happy to talk with folks outside. Thank you.